While the primary focus of the podcast is prostate health, we will occasionally break from prostate health to cover other important urology topics. This week, we have a very special bladder cancer episode. Not only will we start off in reviewing some of the basics of bladder cancer on the episode, but then we'll get you up to speed on what you need to know about bladder-preserving trimodality therapy as an alternative to radical bladder removal for muscle-invasive bladder cancer. So listen in. The show today is brought to you by our sponsor, the Prostate Health Academy. The Prostate Health Academy is launching soon, and this is exciting news. The Academy will be an essential community for individuals wanting to learn more about prostate conditions, connect with like-minded individuals, and improve their overall health. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. We are very happy to have joining us on the Prostate Health Podcast today, Dr. Abhi Solanki. Dr. Solanki is a radiation oncologist. Following completion of residency training in radiation oncology at the University of Chicago Pritzker School of Medicine, he then joined the faculty at Loyola University Medical Center and is currently an associate professor in the Department of Radiation Oncology. He also serves as quality medical director in the department, as well as the chair of Genitourinary Cancer Disease Committee at the Cancer Center at Loyola. Much of his clinical focus includes the treatment of genitourinary cancers, including prostate, bladder, kidney, and testicular cancer. Dr. Solanki, welcome to the Prostate Health Podcast.
Thanks for having me. I'm excited to be here.
So we are very excited to have you helping out with a bonus episode today on bladder cancer. Today, we will be covering the concept of bladder-preserving trimodality therapy as an alternative to radical cystectomy for patients with muscle-invasive bladder cancer. Now, before we dive in, I thought we could just review a few basics of bladder cancer for our listeners. First of all, what are some of the potential signs and symptoms of bladder cancer?
It's a good question, because sometimes it can be kind of difficult to know, what are the specific symptoms of bladder cancer, and many of the symptoms can occur with other conditions as well, which is the most common reason they happen. The main one, the classic one we think about, is blood in the urine. Either blood you can see when you're urinating, or blood that's picked up if your doctor's doing a urine test. Sometimes men and women can have irritative urinary symptoms. So those would be things like having to urinate frequently, or having burning with urination, or having to urgently go to the bathroom, or waking up more at night to urinate. The truth is that, especially in men, these symptoms tend to be more commonly due to an enlarged prostate or an overactive bladder, but sometimes can be how bladder cancer presents. In more advanced cases, there's other types of symptoms people can get. Sometimes people can have a complete inability to urinate. Sometimes you can have back pain if it's more advanced, or fatigue, or appetite or weight loss type symptoms. So many of the symptoms aren't very specific to the bladder as it gets more advanced.
Well, thank you for that. And now, so what are some factors which may increase an individual's risk of developing bladder cancer?
So there's a couple of kind of broad categories. So one, there are some genetic predispositions and alterations that can lead to it, some hereditary syndromes as well. But the more kind of common ones are chemical exposure. So the biggest one is smoking. So people who have a history of smoking or actively smoke, that increases the risk of bladder cancer by about 2 to 3 times. There's also some chemicals like nitrites and nitrates sometimes people are exposed to in the industry that they work in that can lead to it, and some medications can as well. And then the third broad category is something that causes irritation in the bladder. So some people may have a catheter for other reasons that's in place for a long time that can irritate the bladder, or there's certain types of infections or even prior radiation that can cause it as well. And that inflammation leads to the development of the cancer.
Now, when looking at diagnosing bladder cancer, how is the diagnosis typically made?
So usually what happens is the patient will present to a urology physician, and the urologist will first check the urine And then typically we'll do what's called a cystoscopy. So that's where the urologist takes a camera and goes in through the urethra to look inside the bladder. And in the bladder, we'll typically see if there's anything abnormal that they can see. In bladder cancer, one of the common findings is you may see a tumor in the wall of the bladder, and the urologist will usually do a biopsy of it to make the diagnosis of the cancer.
So when we get into the treatment of bladder cancer, it really is dependent upon numerous factors, including the type of cancer, grade, and stage of the cancer, all of which are taken into consideration. Today, however, we really will be focusing in on the treatment of muscle-invasive bladder cancer. For our listeners, that is where the cancer is extending past the initial layers of the bladder and into the muscle portion of the bladder wall. So for individuals with a new diagnosis of muscle-invasive bladder cancer, what are their treatment options?
So there's really two categories of treatments. So the first category, and the one that's more commonly used, is a radical cystectomy, which is removal of the bladder and creation of what's called a urinary diversion. So either creating a new bladder from the small bowel or creating another way for the urine to leave the body. Typically, when radical cystectomy is performed, there's chemotherapy that's given prior to it to help shrink down the tumor. So when the urologist goes in to remove the tumor, it's as limited as possible. The alternative is trying to preserve the bladder using trimodality therapy. And what that means is the first step is the urologist will perform what's called a TURBT. And what that is that's a procedure where the urologist goes in and removes as much of the tumor from the wall of the bladder as he or she safely can. Once that's done, the patient would move on to a combination of chemotherapy and radiation that are given together, like a 1-2 punch almost. The radiation is typically given daily for somewhere between 4 to 7 weeks, with historically 7 weeks being the most common form, and more recently 4 weeks kind of gaining favor based on some studies from the UK. And the chemotherapy, there's different regimens that the medical oncology doctor chooses which one is the safest one for a patient, but is given with the radiation therapy to help the radiation be more effective. After that treatment's done, then the patient goes into follow-up, and as long as there's no evidence of recurrence of the tumor, things are good, and we continue monitoring the patient and hopefully try to prevent having to remove the bladder altogether.
Well, thank you for that. Excellent explanation. And so while radical bladder removal remains the standard curative treatment for muscle-invasive bladder cancer, I think you would agree that over the years, bladder preservation with trimodal therapy has been somewhat underutilized. Would you say that we are now starting to see an increase in the utilization of trimodal therapy?
There is. When you go to scientific conferences and even talking with colleagues across the country, there seems to be a tangible increase in kind of the interest in trying to maximize the effectiveness of trimodality therapy and find a way to incorporate that and offer that to more patients. Part of the reason why I think is that there's more and more data now showing the safety and the effectiveness of it, but there are actually 2 ongoing studies that are testing whether adding immunotherapy to the trimodality regimen of chemoradiation therapy can help improve outcomes. And so that also has kind of garnered a lot of enthusiasm amongst physicians to see if we can have even better outcomes with the approach.
We're going to take a quick break here with a word from our sponsor, and we'll be right back. There is some exciting news coming with the Prostate Health Academy. The launch is just around the corner, where we'll be opening the doors to the Academy. This will be an essential community for individuals wanting to dive in even deeper and learn more about the various technologies available to them for prostate conditions. In the Academy, you will be able to interact with like-minded individuals in the private community forum and have access to exclusive bonus podcast after hours video content with experts, innovators, and leaders in the field. We'll also be keeping up with the latest evidence on a prostate healthy diet and exercise and creating a roadmap for you to keep you on track. For those that don't want to miss out, you can sign up for the waitlist at www.prostatehealthacademy.com. So who would you say would be a good candidate for trimodal therapy?
So the main goal of trimodality therapy is to preserve the bladder function. So the folks that we choose that are the best candidates are those who they have good bladder function at baseline. So if they have a lot of urinary issues, even aside from the bladder cancer, or because of the bladder cancer that we think we won't be able to reverse by doing the chemoradiation therapy, the trimodality therapy, those patients typically aren't great candidates for it because their quality of life may not be that much better by maintaining their bladder, and they may be better off with another form of urinary diversion. Other folks, if they have a very large tumor or what we call carcinoma in situ, which is where there's precancerous cells that are lining the wall of the bladder in multiple areas, those patients may be less ideal candidates, although recent studies show that even those patients may safely be treated with trimodality therapy. And then the third kind of group of patients where we're cautious about trimodality therapy is something called hydronephrosis. And what that is that's where, because of the blockage in the bladder, there's backup of urine up the ureters, which connect the kidney to the bladder. And what can happen is sometimes that can lead to inflammation or infection or even trouble with kidney function as well. And historically, we've thought that those patients may not be great candidates for chemoradiation therapy as well. But again, more recent studies seem to suggest that even those patients, some of them may be good candidates for trimodality therapy.
So when you sit down and counsel some of your patients regarding trimodality therapy, when you talk to them, what are some of the, say risks, but also benefits of the treatment?
Mm-hmm. It's a good question and an important discussion because, what we try to do is there's no one best treatment option for every patient. And it's really a personalized decision, and you make a shared decision, between the clinician and the patient. So first, I usually start out talking about, big picture wise, what's the goal of trimodality therapy? So the goal of trimodality therapy is to say there's this bladder cancer that's invading into the muscle, and we need to do something about it. So one option is to remove the bladder, a new option for urine to exit the body. The other option is to try to save the bladder by doing chemotherapy and radiation therapy. But the difference is that with the cystectomy, once the treatment's done, you don't have to worry so much about surveillance of the area of where the bladder is. Whereas if you do chemoradiation therapy, one key thing is the urologist will have to keep checking every 3 months initially and then every 6 months to make sure that the tumor isn't coming back. And so it's not just chemoradiation therapy. The urologist and surgery is a big part of that treatment. It's just the goal of surgery isn't to remove the bladder. It's to remove as much tissue as you can and then follow it to see if any tumor comes back. In terms of the logistics, it is a little bit of a time commitment, to come in once a day, Monday through Friday, every day for a total of up to 7 weeks. It's no small undertaking, especially for folks who have busy lives outside of their medical condition that's going on. And so that's important to kind of educate the patients about. And then when it comes to the side effects of radiation therapy, it can be divided into short-term or acute side effects that happen in the first couple of months and during treatment, and then long-term side effects that can happen months or years later. And the way I describe radiation is kind of like a flashlight. So the light shines in a specific area, and the good and bad effects of that light are in that area. And that's how the radiation is, where the good effects of treating the cancer is in the area of the bladder, but the side effects are in that area as well. And so the short-term side effects are things like urinary frequency, urinary urgency. When you got to go, you really got to go. Loose stools, diarrhea type symptoms because the rectum is nearby the bladder. Then folks can have some fatigue. Now, part of that's because they're coming in every day for treatment and building it into their schedule, but part of it's because of the radiation as well. Those short-term side effects from the radiation tend to go away in the vast majority of patients a couple of weeks to months after treatment's done. And in the long term, most folks do relatively well and have good bladder function. The other side effect we tell men and women about is that radiation can also cause some trouble with erections. So particularly in men, and vaginal dryness and symptoms like that in women, which can lead to difficulty with sexual function. So that's something that's very important for us to educate patients about. In the long term, the rare side effects that we educate patients about is there's a very, very small chance of the radiation causing a second cancer developing in the area of the pelvis, in the order of 1% or less, and a very small chance that the radiation can affect the small bowel, where it can cause a narrowing or a blockage or even a small puncture in it. Again, very low chance of that happening. But we try to tell patients, all the possible side effects, but also what's likely and unlikely. And most folks, although they have some of these nuisance type urinary and bowel symptoms in the short term, in the long term tend to do relatively well. From the chemotherapy perspective, the chemotherapy treats from the head to the toes, and so there's different types of side effects depending on the specific type of chemotherapy that's used. But that can make you feel a little bit sicker, can make your lab values for your blood counts and things like that go down, and sometimes can predispose to infection during the time of the chemotherapy. But again, in the long term, most folks do well.
So you mentioned, in terms of follow-up after trimodal therapy with cystoscopy or looking inside the bladder to look for recurrence. Now, after trimodality therapy, what options would a patient have for a bladder tumor recurrence?
So it is something that unfortunately does happen. And typically the first form of treatment is actually to do that TURBT procedure again. So where the urologist goes in and removes as much of the tumor. And then you would see, is it invading into the muscle or is it just superficial? If it's just superficial, you can consider just watching it and continuing surveillance or doing some sort of medical treatment that goes into the bladder to treat that area. If it's invading into the muscle, though, that's a little bit more serious of a situation. And typically the standard treatment at that point would be to say, we tried to preserve the bladder and avoid having to do it, but now the safest thing to do is to remove the bladder. And so a cystectomy would be performed. And the studies show that actually the safety, even after the radiation, of cystectomy is good. And so it ends up being a backup option instead of the first option.
I think that's good to know. I mean, even for urologists that are listening to this show, and in terms of, I think there was always kind of that fear that, okay, you've had radiation in the bladder, it's going to be just very difficult to remove the bladder. But it's kind of reassuring now to see that, some of those studies coming out that say that it can be done and it can be done safely. So. Yeah,
I agree. Absolutely. I think that's the nice thing about having a lot of institutions that are studying this approach is that we're getting some great data to help guide us on, who the best patients are and how to manage patients where they have this recurrence, and that it is safe to do cystectomy.
Well, this has all been excellent information, Dr. Solanki. Now, any final thoughts today for our listeners on the podcast?
Well, I think the most important thing is that there are options for treatment. And it's always good to educate yourself before going down the path of any treatment about all of the options that are available. Get opinions with different types of physicians, go to resources that you trust, like this podcast, to learn more about your diagnosis and really, make an educated decision and then, make the best decision you can with the information that you have. And, both the surgical approach as well as the trimodality therapy approach are good options for patients. And it's really a personal preference, and you should feel comfortable with the decision you make.
Well, we really appreciate you taking the time to join us today on the podcast. The information you've provided will really help empower our listeners. We're very thankful for all that you are doing and continuing to move the field forward, not only with bladder cancer, but other genitourinary malignancies as well, including prostate cancer, which I know that you're also very active in. So thank you again for being a guest on the show.
Thanks for the opportunity. It's been great.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate health podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.